Okay. Okay, so now we are changing topic, and we are talking about completely different perspective. The first presentation we talked about the refined techniques of prescribing antipsychotics and pharmacotherapies in general. Here we focus on how we should understand some specific aspects of our depressed patient. This presentation will focus on anhedonia and try to answer to the question that is anhedonia part of depression as we have thought for many years, or anhedonia is something different? And the answer to this question can lead to very different treatment strategies. And so, again, it's important to avoid errors. Because if we consider anhedonia part of depression, we don't consider anhedonia independently, and therefore we treat depression as a whole. But if we are aware that anhedonia is something different, we can avoid the mistake that anhedonia is not treated if we treat only depression. So it is quite complex, but don't worry. During the presentation, I'll try my best to show which is the evidence so far. Everything started many years ago because anhedonia was described more than 100 years ago as an independent disorder at that time. After many years, in DSM-3, you remember it was created in the 1980s to create an agreement for international and American psychiatrists. And DSM-3 made a list, and anhedonia was included in the list of symptoms of depression. So anhedonia lost its status of a single disease to be listed as a simple symptom of depression, like lack of appetite or insomnia and so on. And it remained for a long time just a symptom of the depression. But what is new and why I'm here today talking to you about anhedonia, otherwise it make no sense to discuss one symptom of depression in a presentation, is that recent converging evidence is suggesting that again it should be considered independent from depression. And this leads to a lot of consequences in terms of treatment and management of our patients. Indeed, if you look at the interest that is receiving anhedonia, there must be something there. Anhedonia was part, these are the papers published on PubMed in recent years. It was published, it was part of very few publications until 10, 12 years ago. And in the recent 10, 5 years, there is a kind of exponential increase of publication focusing on anhedonia and anhedonia linked to depression. So let's see what's happening. Let's start from the basis. The basis is that anhedonia is defined by the latest DSM as markedly diminished interest or pleasure in all or almost all activities. This is quite a simplistic definition of anhedonia. Probably, if you think about your patients, I'm thinking to many of my patients, indeed, I remember that they have different kind of anhedonia. Some patients are completely apathetic, they don't care about anything. Others, they have some energy, some of the activities are rewarding for them, but not others. Some mechanism of the reward is working, some other mechanism is not working. So this general definition probably is too general. Also because this definition applies to many other psychiatric disorders. We have anhedonia in schizophrenia. Of course, in the substance dependence, this is chemical induced, of course. in PTSD, in anxiety, eating, autism, and of course in neurodegenerative disorders. So if anhedonia is so broadly distributed, probably is something that is on itself, not just part of depression. But this is just first of the evidence. Let's understand with a couple of slides more in detail what is indeed anhedonia. Originally, it was defined as a reduced ability to experience pleasure or interest in normally rewarding stimuli. That is more or less the definition of the DSM-3. But recently, there has been a lot of discussion and the definition expanded a lot to a spectrum of reward processing deficits. Which exactly? The current conceptualization of anhedonia, that is coming also from the big effort of the research domain criteria that has been done a few years ago in the US, include reward components like interest, motivation, effort expenditure, valuation, reward anticipation, learning, pleasure, and satiation. Let's think a little bit about these points because otherwise it can get confusing. Why a patient or a normal person is anhedonic? Which are the phases? What's happening in the brain and the feeling of these people? Well, it can happen disruptions in different levels. First, you cannot have interest. No, I'm not interested in football game anymore. I'm not interested in volley, in going to a volley, beach volley. Or you could have a lack of motivation. Yes, maybe I'm interested, but why should I go there? No point. Or, yes, it could be interesting. Maybe I can find nice people, but I don't have the energy. Oh, it is very tiresome. I have to take my car, I have to pack my clothes, and then I have to go there, and then go to the beach, and then go back. Valuation, the intensity of the event, and reward anticipation. This is something that we will see later is important. Reward anticipation is a very strong leverage. If you think that you will stay better when you do something. Okay, when I go to play at volleyball in the beach, okay, it is difficult, tiring, but then I feel so good. I remember that I am so happy after a football match, a volleyball match in the beach. But this is reward anticipation, the capacity to anticipate the reward that you will feel when you do something. And if this is missing, of course, you go back to anhedonia. Learning, it means how you can acquire this benefit, the pleasure that you can feel, and satiation, that means the satisfaction of having done something pleasurable. So you have seen in these two lines that the old concept of anhedonia has been broken in many parts. Each of them can contribute to anhedonia. And you will see that those parts are important because each of them is linked to a different brain structure and probably to a different treatment. At the end of the presentation, we will discuss also the treatments. We are in a clinical context here, so it's not just an abstract discussion. I will tell you at the end of the presentation the best options for treating anhedonia. Making things a little bit more simple, we can summarize the various aspects that we've seen before in two broad concepts: anticipatory anhedonia and consumatory anhedonia. Anticipatory is everything that happens before. I am desiring something. So, ability to experience pleasure in anticipation of rewarding. I'm so happy that I will go to play volleyball in 1 hour because I can anticipate the pleasure that I will feel. Consumatory anhedonia, that is the ability to experience pleasure from activities, that is the actual pleasure in playing volleyball in the beach. So if you want a complex definition of the components of anhedonia, these three lines. If you want a simpler and more practical definition, these two lines. Honestly, I prefer these two because the first is too complicated in my opinion and is useful for research, but for clinical practice, this division is much better. The last point that is still unclear and to be discussed is anhedonia a state or a trait? In other words, anhedonia is always there or only during the periods of depression, schizophrenia, the periods when you have other comorbid disorders? This is also a quite open question that we will try to answer as best as possible. First, let's start from the numbers. The numbers are very clear. Anhedonia is extremely common in depression. Up to 70% of patients with depression show a variable degree of anhedonia. Also in the other psychiatric disorders, the prevalence is high. Schizophrenia, substance, it can range to the 30, 40%. So it's quite common in all disorders. If you want to do a study in anhedonia in your centers, I give you a couple of suggestions. These are the two scales that are the most commonly used in practical studies on anhedonia. The TEPS and the SHAPS. They are both good. Probably the TEPS is the more older, the more original, but also the SHAPS has been quite used. Probably is a little bit faster to administer. Both of them are fast. And they are the gold standards. So if you make a study with these scales, you can compare your study with the ones in literature. Here you see, very simple. You don't need to do 18-item self-report, 14-item self-report, very easy. Okay, let's go a little bit deeper on the problem. So far we introduced anhedonia in terms that first, it is very common across many psychiatric disorders. In the past, it was considered a separate disorder. For many years, it has been considered only a symptom of depression. Now we are questioning this point, and probably we are thinking that it can be something separated from depression and is independent. If this is true, then Sidney Kennedy, that is a very, very, very experienced psychiatrist from Canada, is telling us, well, if it is true, then we are doing a big mistake. Because if anhedonia is structurally, physiologically, etiopathologically different from depression, when we treat depression, we don't treat anhedonia, or at least we don't treat complete anhedonia. And then anhedonia remains as a residual symptom. So there is the possibility that therapies are not adequately treating anhedonia, and therefore this could explain the presence of residual symptoms. And this is a very, I would say, not tragic, but relevant point. How many patients we have with depression that have an improvement, maybe insomnia is improving, anxiety is improving, but still anhedonia is there. And then we try with different antidepressants, we don't know what's happening, residual symptoms. We all had patients with residual symptoms. So the key is, what if residual symptoms of anhedonia is because anhedonia is different and we are not treating anhedonia? And this is, of course, a mistake. Because they say, when you look at what happens in the brain of a depressed patient or bipolar in different phases, like remission or depression, you see that it happens something that's very interesting. For example, let's focus on the most interesting part. Remitted measure depression still have um, cognitive distortion because they have a reduced rewards in a response and a reduced reward in learning of positive aspects. So they have this cognitive distortion also when remitted. And this is linked to specific area of the brain that is the inferior frontal gyrus that is here in the front of the, between the two hemispheres. Then this is something that supports the fact that anhedonia could be something different from depression, also because the area is different from the areas that are considered usually part of depression in imaging and functional imaging. While during depressed, of course, there are all the big depression cognitive distortions that are in other areas, the orbitofrontal cortex, the usual orbitofrontal cortex, and so on. But this specific finding in remitted depressed patient is strongly supporting that is something different rather than residual depression. In bipolars, of course, we have not opposite but very different abnormalities in mania and in depression. Therefore, a lot of people recently, in the last few years, focused on which are the mechanisms that are on the basis of the sections of anhedonia. For example, reward liking and wanting are very linked to the striatal hypoactivation and other frontal areas. I will not go into the neuroanatomical detail. I will show you just a slide that is a summary of the finding. But for now, the take-home message for you is that the regional alterations in the brain linked to anhedonia and its mechanisms are partially different from the ones of depression, therefore supporting the concept that anhedonia is something different from depression. Another point is depending from which perspective you look at the ethiopathology of anhedonia. Okay, that orbitofrontal cortex, okay, the area involved, but also the substances. And it seems that the substances involved in anhedonia, neurotransmitters, I mean, are different. Of course, there is dopamine that is central for anhedonia modulation, but not only the usual monoamines, but also opioids. And we will see at the end of the presentation that opioids could be useful for treating anhedonia, glutamate, GABA, and acetylcholine. So both the anatomical, the functional, and the chemical basis of anhedonia is not completely overlapping with the one of depression, and it has its own profile. And therefore, when a patient is in the anhedonic state, there is something that is not working in the usual pathway. This is the usual pathway. When you receive a stimulus, you activate association in your brain, hippocampus, and so on, about what can be happening. Example is, oh, tomorrow we have a volleyball match in the beach. And then you remember, oh, last time I enjoyed it a lot. So you associate and you have interest. I'm interested in tomorrow volleyball in the beach. I have anticipation about how I'll be happy doing this volleyball match in the beach. And I will think about the effort. Okay, then I will prepare my gear, I will go there, and then I will make a plan. I will prepare all my activity, and then I will do the match, expend effort, running, jumping, and thinking. And then I will feel the pleasure of the activity. And then the feedback will be integrated with the memory and for the next time the circuit. Central to this is the expectation. That is something that we have it from before. So something in this mechanism of hedonia, this hedonic mechanism, something is not working in anhedonia. As we have seen from the previous slides, many structures and many substances can reduce one or more of the phases of the hedonic behavior. This is a very complete slide, so you're not expected to read it all, but just to give you an idea that each of these parts, anticipation, motivation and effort, evaluation, expectation, outcome, are linked to some similar but also different um, neural structures demonstrated in animal and in humans, both in terms of circuitry and in terms of neurotransmitters. For example, dopamine, of course, is usually linked with anticipation, while serotonin or GABA or opioid are in the consumatory pleasure. So, not that you have to study all of this, just to give you an idea of the complex machinery that is behind hedonic behaviors. Some regions activate based on memory, some substances activate based on input from memory, and then the circle is going on. This is probably the most comprehensive figure, at least that I found, that combines what we know now. And we know that indeed many areas are very important for hedonic behavior. The accumbens, the ventromedial prefrontal and orbitofrontal cortex that we have seen before, the medial prefrontal cortex, the cingulate, the striatum that we have seen before. So all that area that are here in between the two hemispheres, above the limbic system. And of course, with some input also from the usual amygdala and the usual hippocampus. Given the complexity of the structures involved and their machinery, here we have an answer that it is different from depression, because in depression we have mainly involved the prefrontal cortex and the orbitofrontal cortex. Here also, but many of the other regions are not that involved in depression. So this again confirms that hedonic behavior is different from depression. If you want to go a little bit more in detail, our very nice Viennese colleague did this very complex but funny graph that is an interaction between all the regions that we have seen before, with the center of nucleus accumbens and the connections with orbitofrontal cortex and all the other connections. It is basically the same of what we have seen before with the reciprocal connection. Just if you want to go in detail, you can find easily in literature and the slides will be available for you so you can see them again. So we have seen so far that anhedonia is clinically independent in large part, and it is also independent in terms of physiopathology, in terms of neurotransmitters, in terms of region, and in terms of regional circuits. Now, the last piece of information about the causes of anhedonia, before going to the treatment, that is genetics. You know that I work in genetics, and we are doing many studies in genetics, and of course, also studies in genetics of anhedonia. And the results are very promising because in this quite recent paper, there were many signals across the genome. You know, every dot above the red line is a positive association. And so we have a lot of dots above the red line. That means that Many variants in many genes are probably modulating the anhedonic behavior. This would be a wonderful guide to understand what happens in these genes and what we can reverse on those genes with existing drugs or with new drugs or with targeted antibodies and so on. So to conclude this clinical and physiopathologic part, anhedonia. Anhedonia has a very strong negative prognostic value. It leads to more severe and recurrent disorder, larger number of depressive episodes if you have depression, longer depressive episodes, greater overall severity, and lack of response. Lack of response, we will come back to this later, increased risk of suicidal behavior, and also probably a higher inflammation. And you know that inflammation is strongly linked with depression and many other major psychosis. So, in short, anhedonia is bad. It's not something that we want. If you want to know more about anhedonia, I suggest you a couple of books that are quite well done, in my opinion. The first is this one by Michael Ritzner. It is divided in two books. This is volume one, and it ranges from conceptual aspects to neurobiological aspects. And then there is a volume two that it goes specific in the psychotic disorder, mood disorders, and so on. Quite nice, but probably even better is this one. Why better? Because Diego Pizzigalli, that is Italian, but is working in US, worked for more than 30 years on anhedonia. I would say that Pizzigalli is the most expert in anhedonia. And this book is very interesting because it goes much in detail in terms of history, etiology of anhedonia, special topics, anhedonia in different disorders, schizophrenia, depression, dependence, and so on. Okay, now let's start the question of the treatment. The question of the treatment is quite complicated because first, we concluded now that anhedonia is different from depression. So we should treat differently from depression. But how? Well, the first answer of treatment of anhedonia is antidepressant. Anhedonia, antidepressant, perfect match. No, not so simple. As we demonstrated more than 10 years ago, but not only us, also Catherine Harmer in UK worked a lot on this. Antidepressants, particularly SSRIs, they function, they are antidepressants, but they can lead to the so-called emotional blunting that can resemble somehow anhedonia. I've had many patients that told me, well, doctor, I feel better. I do not have any more anxiety. My mood improves. I can sleep, I can eat. But still, I feel detached from anything. I don't care about things. It's like I'm living in a bubble. This is common. Many patients told me it's like living in a bubble. That according to some theories is good because this could be a mechanism of the antidepressant action. But of course it's also bad because they are not completely back to their normal functioning. And this created a lot of discussion around. Some people is wondering, but emotional blunting that is induced by antidepressants, is it the same thing of anhedonia? So are we doing a double mistake because we treat anhedonia with SSRIs that can cause something similar to anhedonia, and then we are not treating the patient? The question is therefore very difficult at this point. Well, from my experience, I can tell you that anhedonia and emotional blunting are a little bit different. First, because anhedonia is perceived in a negative way. Patients are not happy with anhedonia, while emotional blunting is sometimes perceived not negative, just bothering. or for some patients also positive. I remember a woman that was so happy about her emotional blunting because she told me, oh, in the past I had to clean my house every day. Now I clean once every week and I'm happy all the same. So you have to see case by case. But in any case, it's important to have in mind this possible difference between emotional blunting and anhedonia. In fact, some people, you can see this very recent paper, try to understand the different kind of anhedonias. We can have an endogenous anhedonia with some features. We can have anhedonia that is coming after a stressor, and we can have anhedonia that is coming from antidepressant, the emotional blunting. They are slightly different in terms of manifestation. For example, the anhedonia that is coming from antidepressant does not lead to social withdrawal, but may lead to sexual anhedonia because antidepressants have sexual side effects. So this table could be useful for you to understand which kind of anhedonia is having your patient in that moment. And that can be one or the other, or a combination of the three. And this is why last year I tried to do this review about anhedonia, because I was confused. I was reading things from different perspectives, different opinions. And this, as it happens usually when I see a problem that there's no clear summary in literature, I try to do it myself or with my people. And then I try to summarize current knowledge, but particularly current treatment for anhedonia, for clinicians, for you, for people like you, me, because otherwise we get lost in the 1 million papers in the web. Also because guidelines on this are not very useful. They don't give specific indication about anhedonia. So I summarize the fact that anhedonia comes from a combination of gene variants, pathways, comorbidities, and then we have anhedonia. And then we have to go to the treatment. The treatment that is not clear because, like in the previous presentation case, we don't have many studies. So we cannot do the Cochrane meta-analysis. It's not easy because there are not sufficient evidence. So I did something that can be questionable, but in my opinion can be useful. I gave stars, like 1, 2, 3 stars. Based on what? Based on empirical evidence, because otherwise it's impossible. Some are small studies, some are large studies, some are RCT, randomized clinical trials, some are open trials, some are direct comparison, some are indirect comparison. I know that many people of my colleagues, they do very structured network meta-analysis. I disagree a little bit with them. We have to go to the truth. We have to go to explain what is the best to do. And using very sophisticated methods not always is the best case. In any case, here I decided to do this. So after reading the literature and guidelines, I decided, based on expert opinion, that some of the treatments are probably more effective than others. Is my opinion, of course, but still is based on literature, it's not just my opinion at all. Agomelatine is highly supported as a treatment for anhedonia. Well, agomelatine, I was not using it so much because for some reason other drugs are always preferred. But indeed, agomelatine is well tolerated, good for sleep, and this hedonic effect that is not so strong, but I've seen in some patients, is something that can make consider agomelatine in these cases. Well tolerated, some small interactions, but can be controlled easily. Vortioxetine. Vortioxetine is less surprising because vortioxetine, is characterized by well tolerability and improved cognition. So it is not surprising that can improve also anhedonia. So I would say the first two steps for anhedonia, I don't know if you have these compounds in your country, agomelatine and vortioxetine, I think yes, yes. I would start with one of these two based on the patient. If it is not sleeping, agomelatine. If it is oversleeping, vortioxetine, for sure. These are the two parts that you can also combine with existing antidepressant treatment, unless there are interactions, of course. Ketamine, well, ketamine is not surprising. Ketamine is treating everything, so in few hours, but of course it's less practical and very expensive. And then there is very strong evidence, the last with 3 stars, transcranial magnetic stimulation, particularly with the new rapid methodology. This is very good because it's a physical treatment without any chemical, very natural, very well accepted by patients, but you need the machinery, so it's expensive, at least at the beginning. The ones of you that have a TMS machine should consider using it more for anhedonic patients. Anhedonic patients, I mean patients that have maybe treated for depression, but they have residual anhedonia, for example, after you control for the emotional blunting induced by SSRI. And then there is the famous psilocybin. Psilocybin is very promising treatment, but you know is still a controlled substance in the control table of almost all governments. So I'm sure that psilocybin will have a future. We are now writing a review about psilocybin use, but still it should be more tested, I think, at present before be used. In any case, it's not in the market, it's just experimental. While in the market, we have bupropion. Bupropion, you know, bupropion, pure dopaminergic, is wonderful for anhedonia. Indeed, in many patients, I had very interesting results with bupropion. Low doses, 150, maximum 300, combined with the SSRI, bupropion is really a good choice. And now there is this new combination with dextromethorphan that should also stabilize the dextromethorphan pharmacodynamic and therefore also the glutamatergic system. So it's a wonderful combination we don't have in Italy. I'm really looking forward to have this bupropion and dextromethorphan combination as soon as possible. The other possibility is sertraline and fluoxetine. Why these two? Indeed, there are 2 studies with 2 stars I put, because it makes sense, because sertraline and fluoxetine are the only 2 SSRI with a relevant dopaminergic effect on the transporter, dopaminergic transporter. And therefore, they are a little bit like bupropion. And therefore, it makes sense that they can improve anhedonia. And they are the ones that give less emotional blunting. So it's okay. In the same direction, venlafaxine. Venlafaxine at very high doses, like 300, 375, you have a very strong dopaminergic transporter blockade. So it is relevant in this sense. Well, methylphenidate could be useful. There is evidence, but we must be careful because in many countries is controlled, so should be very careful. While cognitive behavioral therapy and behavioral activation are okay, of course. All the non-pharmacological treatments are very useful and can be used, like in the previous presentation. When possible, it's okay. The problem is that are expensive, take time, usual problems, but when possible, they for sure are useful. As you see, the selective serotonin reuptake inhibitors, only 1 star, because there is this overlap with emotional blunting. So treating anhedonia with paroxetine or something similar that can give emotional blunting is a very challenging situation. You don't know what you're curing, so it's quite difficult. And finally, pramipexole, dopaminergic agent, but there is not much evidence. So I think you can use this table. Is in my review. Is for free, by the way. This review is open access. You can download without any problem. And I think it can be useful in clinical practice. Also because previous attempts, this is 4 years ago, when colleagues tried to make a review about anhedonia treatment, they did not conclude much because they said, okay, a lot of treatments have been performed, some are working, some less, but they don't give clear indication. I don't like this kind of papers where there is no clear indication. Maybe my table is wrong, I don't know. But at least it's clear and it gives an indication based on evidence. Um, they say, okay, we need continuous research with more studies. Okay, but we need also answer if possible. An answer that is coming from ketamine. Ketamine studies for anhedonia are really wonderful because indeed ketamine, when is effective in very short time, 1 2 hours, emergency treatment. So it is promising, but consider that intravenous ketamine is not very practical. And consider that nasal ketamine is a little bit more practical, but expensive, and you need 2 hours observation, so it's not very manageable, but still could be an option. And the last one is a kind of innovation. You are probably aware that at present we have many new drugs under development, various stages, phase 1, 2, 3. And this is one that is very promising, that is a compound that is modulating the kappa opioid receptor. You know that there are different opioid receptors, some are linked to abuse, delta, and so on. The kappa is useful because it's been associated with mood, anxiety, and things. And so this is for the first time an advanced technology of trial, so-called fast fail, to see if this kappa opioid receptor antagonism was okay for treating anhedonia. Indeed, the results are very interesting because they tested if it could counteract and modulate the brain functional abnormalities observed in anhedonia. And indeed, it worked and it was well tolerated. So the trial is going on. It is called AT Caprant. And if it will finish successfully the study, you will have it in the market soon as a specific treatment for anhedonia. So that would be really something very interesting. So I think we are sufficiently in time for the conclusion of this presentation. What I would like you to remember about what we have done today. Well, anhedonia was considered independent 1 century ago, and then it has been considered as a symptom of depression for a very long time. Now, probably we go again in considering anhedonia something independent. This has a lot of consequences because this independence that has been demonstrated by neuroimaging, by functional neuroimaging, by genetics, and by clinical and by timing of outcome, must lead to a different treatment approach. So we should not use the standard antidepressant approach. We have to use targeted approaches. And about treatment, be very careful to use anhedonia with antidepressants because inducing emotional detachment can slow down the treatment of anhedonia. Can function as well, but probably less, and not in all subjects. And so there are other treatments that can be combined with the antidepressants that you are using to treat the residual symptom of anhedonia, if any, of course. And these are the ones that I mentioned: vortioxetine, agomelatine, venlafaxine, checking for interactions, of course. Genetics may be useful, yes, because in the future it will be probable that the genetic studies that are being performed at present will point some regions of the genome and therefore proteins that should be targeted for anhedonia. And in this case, we will do it like has been done for other diseases, use another drug, another target, or a new drug, or a new antibody to target specific aspects. But I tell you this to expect this, but it's not yet available. The final point is the same that I'm telling around in congresses since the last 20 years. Every patient is different. So there is no universal treatment for anhedonia. You have to see the specific symptomatology profile of your patient, the outcome of your patient, and then combine this with the available knowledge from the data that I give you today and others to find the best treatment for anhedonia in that patient. Thank you for your attention.